Statins are one of the most commonly prescribed medications in the U.S. There are many statin options available. In fact, there are 7 total. Today, we're going to briefly review the key differences between these statins. Importantly, not all statins are the same. Each patient with high cholesterol requires an individualized plan to help them achieve their cholesterol-lowering goals. After going through some of these differences, we'll spend the rest of our time highlighting 5 examples of patients who may be on statins and would require a more tailored approach to lowering their elevated cholesterol. The key difference between the 7 available statins in the U.S. is how they're metabolized. Most statins are metabolized through the cytochrome P450 system, or CYP450 for short. Lovastatin, simvastatin, and atorvastatin are metabolized primarily through an enzyme called cytochrome 3A4, whereas rosuvastatin and fluvastatin are metabolized mainly through cytochrome 2C9. Why is this important? 70 to 80% of all drugs in clinical use, including the ones we just listed, depend on cytochrome P450 enzymes for their metabolism. And because of this, medications that use this pathway are subject to the risk of drug-drug and drug-food interactions. Pitavastatin and pravastatin both have a reduced potential for certain drug-drug interactions, as they both primarily bypass this pathway. Notably, pitavastatin, also known as the brand name Zypitamag, is primarily metabolized by a process called glucuronidation. More about Zypitamag, or pitavastatin. This medication has a unique structure that allows it to bypass metabolism by the CYP450 family of enzymes. It also has a high binding affinity to the enzyme in our body that produces cholesterol, HMG-CoA reductase. Zypitamag is available in 2 mg and 4 mg formats. It's taken once daily at the same time each day and can be taken with or without food. In terms of side effects with Zypitamag, the most common side effect reported with Zypitamag in controlled clinical studies were constipation, diarrhea, muscle pain, pain in the legs or arms, and back pain. Rates of muscle pain were 3.1% at the highest dose of pitavastatin, 4 mg. Discontinuation rates due to adverse reactions with Zypitamag are less than 4% and are not dose-dependent. Here are the 5 patient examples we'll be going over today. Those who are living with type 2 diabetes, those who are over the age of 65, those who are of Asian descent, those who are taking multiple medications, and those who have more than 2 risk factors for coronary heart disease. Focusing in on patients who have type 2 diabetes. According to the most recent 2018 ACC/AHA guidelines, in patients who have type 2 diabetes are between the age of 40 and 75 and have an LDL cholesterol over 70 mg per deciliter, it is recommended to be started on moderate intensity statins, regardless of their 10-year atherosclerosis risk score. Importantly, increases in HbA1c and fasting serum glucose levels have been reported with statins, including Zypitamag. In a post-hoc analysis of a randomized, double-blind, active-controlled, multinational non-inferiority study that compared the long-term efficacy and safety of pitavastatin with atorvastatin in patients with type 2 diabetes and combined mixed dyslipidemia, pitavastatin 4 mg demonstrated a non-significant change in fasting blood glucose levels compared to baseline versus atorvastatin 20 mg. The study concluded that reductions in LDL-C and changes in other lipids were not significantly different in patients treated with pitavastatin 4 mg or atorvastatin 20 or 40 mg. However, pitavastatin may have a more favorable effect on the glycemic status. Generally speaking, for those taking statins, there is a modest increase in risk of incident diabetes mellitus, particularly in patients who have a predisposing risk factor for diabetes mellitus, those with components of metabolic syndrome, and those who are taking high-intensity statins. The risk is outlined in the 2018 ACC/AHA guidelines for the management of blood cholesterol. It is recommended to optimize lifestyle measures, including regular exercise, maintaining a healthy body weight, and making healthy food choices. Switching over to patients who are over the age of 65. Pitavastatin has been studied in over 1,200 patients greater than or equal to 65 years of age. A key consideration for this patient population is drug-drug interactions, especially given that these patients may be taking multiple medications due to other comorbidities. Both pitavastatin and pravastatin have reduced potential for certain CYP450-mediated drug-drug interactions compared with other statins. Importantly, zypitamag is contraindicated in patients taking cyclosporin and not recommended in patients taking gemfibrozil. The following drugs, when used concomitantly with zypitamag, may also increase the risk of myopathy and rhabdomyolysis. Lipid-modifying dosages of niacin greater than 1 gram per day, fibrates, and colchicine. Patients who are of advanced age, which is typically defined as older than 65 years of age, are at an increased risk of myopathy and rhabdomyolysis. In general, dose selection for this patient population should be cautious, reflecting the greater frequency of decreased hepatic, renal, or cardiac function, and of concomitant disease or other drug therapy, and the higher risk of myopathy. In pitavastatin-controlled clinical studies of 545 patients, 43% of patients were over the age of 65. There was no significant differences in efficacy or safety between older and younger patients. In addition, a clinical study looking specifically at patients over 65 years of age demonstrated that pitavastatin provided superior LDL cholesterol lowering than pravastatin. For patients of Asian descent, there are a few important considerations when initiating statin therapy. According to the 2018 ACC/AHA guidelines, Japanese patients may be sensitive to statin dosing. In Asian patients, consider a lower starting dose of rosuvastatin. Caution is urged as dose is up-titrated. Lastly, in adults of East Asian descent, other statins should be used preferentially over simvastatin. In people of Asian descent, the drug metabolism pathways can sometimes lead to increased accumulation of statins. For pitavastatin, there is no dose adjustment needed for patients of East Asian descent. The efficacy and safety of pitavastatin has been studied in patients of Asian descent, including a long-term prospective post-marketing surveillance study in approximately 20,000 patients. For patients who are taking multiple medications, it's important to make sure those medications do not interact with each other. Drug-drug interactions can cause adverse drug reactions, including an increased risk of myopathy and rhabdomyolysis in patients taking multiple medications. 70 to 80% of medications in clinical use depend on the same enzyme system, cytochrome P450, for metabolism. Pitavastatin undergoes minimal metabolism by the CYP450 enzymes, and therefore has a reduced potential for certain drug-drug interactions compared with other commonly used statins. The table on the right shows a list of several medications in which zypitamag does not have any dose restrictions or limitations, including diltiazem, itraconazole, warfarin, enalapril, digoxin, grapefruit juice, atazanavir, darunavir and ritonavir, lopinavir and ritonavir, and ezetimibe. For warfarin, patients should still have their PT and INR monitor when it's added to their therapy. Zypitamag is contraindicated in patients taking cyclosporin and is not recommended in patients taking gemfibrozil. The following drugs, when used concomitantly with zypitamag, may also increase the risk of myopathy and rhabdomyolysis. Lipid-modifying dosages of niacin greater than 1 gram per day, fibrates, and colchicine. And our last patient group we're discussing today, patients who have multiple risk factors for coronary heart disease. According to the ACA/AHA guidelines, the major risk factors for coronary heart disease include cigarette smoking, hypertension, low levels of good cholesterol or HDL-C, a family history of premature coronary heart disease, and a patient's age and gender. Importantly, pitavastatin's been studied in comparison to simvastatin in a randomized controlled trial with 355 patients who have multiple risk factors for coronary heart disease. In this patient population, LDL cholesterol reduction was up to 44% with pitavastatin 4 mg. This was similar to simvastatin 40 mg. Another important point to consider in this patient population is that they may be taking other medications, such as blood pressure medications. Pitavastatin does not require any dose adjustments with antihypertensive medications, such as amlodipine and diltiazem. Cholesterol management for patients can be a challenging experience and sometimes requires trialing several statin options before finding the right one for them. Not all patients are the same, and not all statins are the same. Just because one statin doesn't work doesn't mean another will not. And remember that pitavastatin may be a good option for many patients. Important safety information for zypitamag pitavastatin tablets. Indications and usage. Zypitamag is indicated as an adjunctive therapy to diet in adult patients with primary hyperlipidemia or mixed dyslipidemia to reduce elevated total cholesterol, low-density lipoprotein cholesterol or LDL-C, apolipoprotein B, triglycerides, and to increase high-density lipoprotein cholesterol or HDL-C. The effect of zypitamag on cardiovascular morbidity and mortality has not been determined. Contraindications. Zypitamag is contraindicated in patients with known hypersensitivity to product components, in patients with active liver disease, which may include unexplained persistent elevations in hepatic transaminase levels, in women who are pregnant or may become pregnant, in nursing mothers, or in co-administration with cyclosporin. Warnings and precautions. Myopathy and rhabdomyolysis. Risk factors include age 65 and greater, renal impairment, inadequately treated hypothyroidism, concomitant use of certain drugs, and higher doses of zypitamag. Zypitamag is contraindicated in patients taking cyclosporin and not recommended in patients taking gemfibrozil. The following drugs, when used concomitantly with zypitamag, may also increase the risk of myopathy and rhabdomyolysis. Lipid-modifying dosages of niacin of greater than 1 gram per day, fibrates, and colchicine. Discontinue zypitamag if markedly elevated CK levels occur or myopathy is diagnosed or suspected. Temporarily discontinue zypitamag in patients experiencing an acute or serious condition at high risk of developing renal failure secondary to rhabdomyolysis, such as sepsis, shock, severe hypovolemia, major surgery, trauma, severe metabolic, endocrine, or electrolyte disorders, or uncontrolled epilepsy. Inform patients of the risk of myopathy and rhabdomyolysis when starting or increasing zypitamag dosage. Instruct patients to promptly report any unexplained muscle pain, tenderness, or weakness, particularly if accompanied by malaise or fever. Immune-mediated necrotizing myopathy, or IMNM. There have been rare reports of IMNM, an autoimmune myopathy associated with statin use. IMNM is characterized by proximal muscle weakness and elevated serum creatine kinase, which persist despite discontinuation of statin treatment, positive anti-HMG-CoA reductase antibody, muscle biopsy showing necrotizing myopathy, and improvement with immunosuppressive agents. Hepatic dysfunction. Increases in serum transaminases can occur. Rare post-marketing reports of fatal and non-fatal hepatic failure have occurred. Consider liver enzyme testing before initiating therapy, and as clinically indicated thereafter. If serious hepatic injury with clinical symptoms and/or hyperbilirubinemia or jaundice occurs, promptly discontinue zypitamag. Increases in hemoglobin A1C and fasting serum glucose levels. Increases of each have been reported with statins, including zypitamag. Optimize lifestyle measures, including regular exercise, maintaining a healthy body weight, and making healthy food choices. Adverse reactions. The most frequent adverse reactions with a rate of greater than 2% are myalgia, back pain, diarrhea, constipation, and pain in the extremities. This is not a complete list of all reported adverse events. For additional information, please refer to full prescribing information. You're encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.